So yes, as I'm from Kelowna, this is the Ogopogo overview. So what we'll talk about here first is a basic overview of what Parkinson's disease is and what the cause of Parkinson's is. And then I'll take a break at the end of that section for questions to check if everyone's got a reasonable understanding of that. And then we'll get into some of the different symptoms. So we'll start with a section on the motor symptoms, which is movement. And then after that, some of the other symptoms that can happen commonly in Parkinson's disease. I'll stop again for questions after that section, and then I'll do a little wrap up with what's happening in the field with research and treatment plans. So I want to start as well with a bit of a take-home message summary for you as well. I hope everyone takes something away from this and learns something, because I see the most important part of your treatment, the base of the pyramid, if you will, is information and understanding your illness. So hopefully we can get some information to you that you didn't know before. So the points I want to get across today about Parkinson's are a few things. So the cause of Parkinson's is really a problem with what's happening inside the cells. So brain cells do a lot of different things in terms of metabolism, and you can think of that like manufacturing, which is a process that requires all kinds of different parts to work. So if one part of the machinery is broken, then it can lead to a problem with the end result, which is production of a package, let's say. So that package might contain dopamine, and so you can have many different problems that lead to that issue with the dopamine at the end of the day. There are other brain chemicals that are affected as well, but that's the analogy I'd like you to think of as we're talking about what causes Parkinson's and how it works. The second point I want to get across is that your brain is working for you, and it has been working for you if you have this illness probably well before you ever had symptoms, to try and make up for the manufacturing problems that are going on. So you need to be good to your brain and nice to your brain to help it do that hard work to try and compensate for the illness. So it's always really important to get good sleep, good nutrition, and exercise is helpful in that regard, and probably over and above that, it has other effects on improving your manufacturing process in the long run. There are some medications that can add ingredients to the manufacturing process. That's where we'll talk about different treatments for Parkinson's and what they might help support. But it's important to know that not everybody needs medication. We need to treat patients when they have disability, and what our goal is to try and minimize that disability wherever possible. And so that often requires medication, and the medication needs change over time. But there are other things that are also important. So that's kind of the, I'm starting with the end in mind, like a Quentin Tarantino movie. And hopefully we can refer back to this set of principles during the talk. Okay, so I'm not seeing any alarm or objections on the chat. I'll keep going then. So I like the analogy of a rusty barrel to describe what happens with Parkinson's disease, because when you have a rusty barrel, it's a problem that takes a very long time before the barrel gets a hole in it and springs a leak. And I think that's a good way to think about Parkinson's disease. You only notice the leak when it starts happening, when there's tremor or stiffness or slowness or problems with walking and balance. But when you notice that, if you take a close look, well, there may have been something going on for quite a while. And that something is a gradually progressive problem that requires certain conditions. So a barrel is not going to rust if it's got no metal, and it's not going to rust if there's not a combination of moisture and oxygen to oxidize the metal. Similar kind of analogy with Parkinson's disease. Some people have a sort of predisposed set of conditions where their gene code might make them more at risk for Parkinson's. But even if you're at high risk, you may never get Parkinson's if you're not putting that barrel under those conditions. So if you keep the barrel in a vacuum chamber, it's never going to rust, even if it's got a tendency to. I'm stretching the analogy, but I hope you understand what I'm saying. So it's caused by a combination of your risk profile, which is like to do with your genetics, and then what stresses you put on your body through life. And many of those things you have no control over. Some of them you do have control over. But that's how I would like to think about the process as well. So here we go with the analogies. You'll see I like analogies a lot. I see a question. I'm going to answer this one on the fly because I see Karen has written there, how many years do people have the disease before symptoms start showing? So I'll talk about this a bit more when we talk about the non-motor symptoms as well. But we think that Parkinson's disease is affecting the brain probably many years before. Many people will notice symptoms in hindsight that were 5 or 10 years before their diagnosis that may be related. So, and it's probably different for everybody. So, so dopamine, you've probably all heard about dopamine as an important part of what's happening in Parkinson's disease. This is a set of diagrams from an article about the cause of Parkinson's disease. Most people, when they think about Parkinson's, they think about dopamine because the dopamine system in the brain is responsible for controlling when you start movements and how you select movements. And if you see, I'm not sure if you can see my hand or my mouse pointer here. If you could just let me know if that's true, then I'll keep using it as a pointer. Otherwise, I think there's a way for me to use a pointer. You can see it. Okay, so there's my little circling hand. Good. Oh, there's a green arrow as well somewhere. Okay. Let's see here. All right, I'll keep using the hand. So these blue areas here are little parts inside the brainstem. So the brainstem is like the trunk of the tree for your brain. It's at the back, deep inside. And in the brainstem, you have this little stripe of darkness that is called the substantia nigra. And that's where the dopamine cells actually live. And you can see these little red lines that send little sort of connections or basically little tubes to parts of the brain kind of up more near the surface of the brain, but deep inside here, the basal ganglia. So these little tubes basically take the dopamine that's produced in these cells and release it where it does its job up in the basal ganglia. So on the left side of the screen over here, where it's green, you see what would happen in a normal healthy brain. You have lots of these little tubes taking dopamine where it's needed and releasing it. And in a brain where there's a problem with dopamine production, where the dopamine cells are not healthy, you only have a few of these little tubes that are still sending dopamine where it's needed. So there's a bit of a problem with how the diagram depicts the medication levodopa working, because levodopa doesn't just go directly to the basal ganglia. It actually is taken up by the surviving cells. So these cells that are left, they take levodopa and release it, turn it into dopamine and release it. I'll talk more about levodopa later on, but this is the idea. So you have a problem with production of dopamine and release where it needs to work in the brain to control movement. So this basal ganglia area up here is like a computer for movement, and then that sends a signal to the movement system in your motor cortex up here, and then that sends a signal down to your spinal cord. So you could think of it sort of like a conductor that's directing the orchestra. So even if the orchestra, which would be in that analogy, the pathway from the cortex down to your spinal cord, if the orchestra is fine and they're ready to play, but the conductor is not able to show them what to do, then they're not going to make any music. So hopefully that's clear. I'm just checking quickly. Yeah, that seems like there's no major objections or questions there on the chat. So just to show you what this looks like in an actual brain, so the top part of this screen here contains a slice of that midbrain. I'll just review where that is in this picture. So this midbrain here, if you look at it under a microscope, if a patient has an autopsy, in a normal brain it looks like this, and you see this little dark stripe here. This dark stripe is what's called the substantia nigra, and that was named by an old-time pathologist who saw this dark stripe and used the Latin name for dark, basically, for it. And you see in Parkinson's disease, there's a lack of that dark stripe. So this indicates that on both sides of the midbrain, in this case, there is a lack of these dopamine cells. So I'm going to come to your question, Carl, when I break in a few slides here. So we've talked about the overview of Parkinson's as a rusty barrel. It's a gradually progressive problem that has to do with production of this brain chemical dopamine and other things. And we can see that the dopamine cells are lost when we look at the midbrain at autopsy. So people have wanted to know for a long time, well, what's causing that degeneration? So why do some people lose those cells, and what happens? So from pathology and autopsies, we know that there's little clusters of protein called alpha-synuclein that deposit throughout the brain in Parkinson's disease. And there have been a lot of insights about how Parkinson's happens from research, from genetic research studies. And I'm going to give you hopefully a fairly simple overview of that without getting to the detail. But first, I'm going to show you this very busy and ugly slide, and I'm not going to explain it very much. In this slide, you see a dopamine cell here, and you can see it's got all kinds of different parts here. And then you see some other cells. So this here is, I think this is the medium spiny neuron, which is a different kind of neuron. And then this is supposed to be a glutamate neuron. So these types of neurons all live in the basal ganglia where the movement computer is. So that's all you really need to take away from that. And there's a lot of different stuff happening inside those cells. So this, if I go back to the slide from a few slides ago, so this cell that's here in green is one of these little cells that sends its axon or tube up to the basal ganglia to release dopamine. So skipping back ahead, so the dopamine release is happening here and the basal ganglia is here. There's other stuff that's interacting with the dopamine when it's released. So I want you to think about that basal ganglia and think about it as the end point of a recycling depot or something. So this is an example of a poorly organized recycling depot. So here there's far too much junk here. There's different kinds of junk. It's all built up and piled. And there's a problem with sorting it because there's multiple different things. It's not being sorted properly. If you need to move stuff around, well, your transport system is lousy here. And you can imagine the factory equipment that you'd have in that could also be broken down. So this is kind of the analogy of how the different genetic discoveries have shown us problems in Parkinson's. These types of problems inside the dopamine cell lead to accumulation of these proteins like alpha-synuclein that cluster and form Lewy bodies. So either there's too much junk produced inside the cell, and I'll get more into why that might happen later. There's problems with moving stuff around within the cell, moving that junk to the waste disposal facility or the factory equipment that needs to dispose of it. Or there's problems with how the junk is distributed in the cell. So the type of gene problems that we have that cause Parkinson's have to do with all this kind of stuff. It's waste disposal and waste management inside your brain cell. Does that sort of make sense? I hope it makes sense. I'll take no answer as a yes. So good. Okay. Thanks, Karen. So if we then sort of zoom out a little bit and think about the big picture, so you've got your recycling depot, and the efficiency of your little recycling depot inside the dopamine cell is determined sort of by your genetics, your genetic background. But you may throw all kinds of waste into that recycling depot or garbage disposal pathway, or you may throw very little waste at that system based on what happens in your life. So this comes back a bit to what Carl's question is. If you have repeated head injuries, for instance, you put your brain cells under a lot of stress, and there's some damage to parts of the brain cell that means that they need to dispose of components in the cell. So if you have to do that a whole lot and you've got a well-oiled machine there, a good functioning metabolic pathway in your cell for waste disposal, that might not be a problem. But if your system is impaired for some reason, then a little bit of stress might be too much for it to handle. So those things that happen to you in your life, which we'd call risk factors or protective factors, and the stressors you put on your brain cells, might lead to them not working well. So over a span of years, if the brain cells aren't working well, they may then start to die off. And when that happens, your brain is working hard to try and make up for the problem and pick up the slack. It can do that really well for quite a while usually, but at some point your brain can't make up and compensate for the problem, and that's when people have symptoms. So does that make sense? That's kind of the main overview of how I would think about Parkinson's and what happens before your symptoms. And the point of this is very different. These environmental stressors, the risk factors, protective factors, and the genetic background or how the recycling system works inside your brain is very different for each person, whether or not they have Parkinson's. And it's determined by, not hundreds or thousands, but millions of different factors in your gene code. Okay, so what might happen then if you start having problems with the waste disposal? You start building up these Lewy bodies. And so studies of what happens in the brain through Parkinson's disease have shown us that Lewy bodies tend to kind of spread in certain patterns through the brain. So this pathologist named Brack described different stages. So stages 1 and 2 happen before people have motor symptoms, and that is when we see Lewy bodies in the lower parts of the brainstem. So that this is a part of the brainstem called the medulla, and this is a part of the brainstem called the pons. The midbrain is this little thing up here that looks like it has a bit of a beak, and that's where the dopamine cells are. So this midbrain up here is the same midbrain we were talking about back here. So the midbrain, you'll see in this picture, is affected in stages 3 and 4. So that's when there's problems with the dopamine cells because they live up here in the midbrain, not down here. And when you have problems with the dopamine cells, they can't control the movement computer, and you start getting motor symptoms like problems with tremor, stiffness, slowness, etc. For some people, but not all people, there will be distribution of these Lewy bodies in a more widespread way throughout other parts of the brain, including the cortex. And that may change over time for patients, and some patients may not experience problems that relate to that, but that can result in some other emotional disturbances, memory problems, or cognitive problems or problems with your thinking processes. So this is to emphasize that when the disease has started before you have motor symptoms here, that you may have other symptoms that relate to problems in the medulla or in the pons where there's other brain chemical systems. And so the dopamine cells live up here primarily, but serotonin cells and acetylcholine cells that have functions in the brain may live lower down and may be affected early. Okay, so this is the heavy-duty part of the presentation, and that's pretty complicated stuff. I have only a couple more slides before a break where I'll spend some time answering questions. So there are two other important things that we've learned from research that I want you to kind of know about and understand. One of them is that Lewy bodies, those little clusters of alpha-synuclein, they spread through the brain in Parkinson's disease. The most compelling piece of evidence for this is from stem cell and grafted cell research. So there were some, you could think of them as stem cells grafted into some patients with Parkinson's disease in a research study, maybe 20 years ago now. And what was found from following those patients is that the new cells put into the brain, they catch Parkinson's disease basically. They get Lewy bodies in them as well. And so that was a very compelling piece of research that showed us that this alpha-synuclein and these Lewy bodies actually kind of progress and spread through the brain. And so what the field has been trying to do since then is determine a way to stop that from happening. And we'll come back to that kind of near the end of the presentation. There's another really interesting and important thing, which is very kind of a hot topic in the field, which is that um, the parts of your body that are exposed to the environment, so your nose and your olfactory tract, which is where your sense of smell kind of happens, and your gut, your gastrointestinal system, those probably serve as some kind of entry point or initiating point for the problem that leads to Parkinson's. One of the interesting things that has supported that idea in the last few years is a big Danish study from Denmark where they followed some patients for about 20 years. This is tens of thousands of people. And they looked at a very simple question. So some patients had basically severing of something called the vagus nerve for a problem they had with stomach acid, basically. That's called a vagotomy. And patients who had that had lower rates of Parkinson's disease than people who did not. And so that was very interesting because that was suggestive that perhaps what's happening in the nervous system in your stomach and your gut, in order for it to get into the brain, it may kind of go up along the vagus nerve. So this is also a very hot topic in the field right now. That may apply to some but not all people. Please don't go and ask someone to sever your vagus nerve as a result of this presentation. That's sort of a joke. Okay, so we're near the home stretch before question time. This is some information from now about 8 years ago for how many people have Parkinson's in British Columbia. So you can see there's 3 different lines here. So the green line is sort of all patients. The blue line is a graph of men, and the red line is a graph of women. And this is little age brackets here. So you can see as people get older, the rate of Parkinson's per 100,000 people gets higher. And you can see if you look at around age 65 to 69, so the rate overall is maybe 500 per 100,000. That's about 0.5%. And then if you go up to age 85 plus, the average rate is 2,000 per 100,000. That's about 2%. This is pretty much in keeping with what we think the overall risk of Parkinson's is for most patient groups around the world. But we know from these data that there's probably about 12,000 people with Parkinson's in the province. Here in the interior, there are quite a few as well. But anyway, this is a province-wide presentation, so I won't dwell on that. Talking about those risk factors and protective factors, we've learned from research a few things that put you at higher risk, including rural living, exposure to certain pesticides, head injuries, again, pertinent to your question, Carl, and well water drinking. And there are also some things that put you at slightly lower risk. So coffee is a good one, and I'm a fan of that, but some people with tremor find it makes tremor worse. Nicotine is interesting, but I'm not a fan of that. Smoking is worse for you than this very small long-term impact on lowering your risk for Parkinson's. But it's interesting, the topic. If you have questions about it, I can answer them. Anti-inflammatories and exercise. So this kind of information here goes back to the stresses that you put on your system. So these are things that you sort of have some control over. There are also things that you have no control over. So where you're born and where you're raised, you have very little control over that. And so some of these are what we would call modifiable, and some are non-modifiable risk factors or protective factors. I'm going to actually stop here, I think, for questions. It seems like I feel like I've said out an awful lot of stuff here, and I feel like it's probably a good time to take a little break and see if anyone's got questions at this point. I'm just scanning here. See, I think I've touched on Carl's question and Karen's question from earlier. Okay, Karen, good question. So the question here is, does everyone have Lewy bodies or just people with Parkinson's disease? Well, there is something called incidental Lewy body disease that we see when people with normal brains and no neurological symptoms have autopsy for other reasons, and they're examined closely for them. So we do see Lewy bodies in some people with no symptoms of Parkinson's disease. It's a dramatically different degree when you do have the illness. I see there's one question in being composed at the moment, and I'll take that question, then I'll move on. What type of anti-inflammatories may lower the risk of Parkinson's disease? Would an anti-inflammatory diet help? Um, the types of anti-inflammatories that were looked at to kind of come up with this as a protective factor is from databases of tens of thousands of people again, and sort of indications of what types of medications they've taken. So anti-inflammatories like ibuprofen and naproxen, if they're listed in those databases, were counted in this group of medications. And people who had higher cumulative exposures to those had slightly lower rates of developing Parkinson's disease. People have then looked specifically at trials of patients with Parkinson's disease, and if they take these, does it help them? And the answer is not really. But it's an interesting thing in terms of figuring out ways we can hopefully slow progression or protect people from Parkinson's. There's something to maybe harness there. Couple more questions there. So, would nicotine in coffee help control Parkinson's? So, it's an interesting topic. So, coffee was studied for a problem that's very common, which is fatigue in Parkinson's. I'll talk about that a bit later. And it showed that there was a small impact on fatigue symptoms in Parkinson's, but not huge. But the other interesting thing is that study showed unexpectedly that there were improvements in the motor symptoms of Parkinson's in patients who were given caffeine pills compared with sugar pills. So that was then put into a further research trial that's still not resulted or reported. So coffee, if it does not cause you problems with heart or anxiety or tremor, it's reasonable for people to take, and I leave that usually to the patient to decide. Mary's question: is there a connection between hemochromatosis and Parkinson's? Well, there is a lot to talk about with respect to iron in Parkinson's. So, iron does deposit in the back of the brain, the brainstem, and in the midbrain in Parkinson's disease. We don't know if that's a cause or an effect of having the problems with metabolism there in the brainstem. So there's also some interesting information about iron deficiency. So people who are iron deficient in their whole system, like if we check blood iron levels, have slightly higher rates of Parkinson's. And so there's a warring two pieces of information there. So peripheral iron, or iron in your body, if it's deficient, maybe a bad thing. But too much iron deposited right in the brain is a sign of something bad happening. So that's something that's being studied further with some treatments for the progression of Parkinson's. If we remove iron from those parts of the brain, is that a good thing or not? I'm going to move on to talk about a couple of these things in more detail as examples, and then we'll get into the motor symptoms. So there was a study back now about 2 years ago, which was interesting, an interesting example about environmental risk factors. So there was this study that looked at people who drank milk in Hawaii in a certain period of time. So in the 1980s, there was a pesticide that was used in pineapple fields called hepatochlor. Hepatochlor epoxide would get into the groundwater, and then cows would get that by eating grass and whatnot, and then it would be in the milk. So people who drank milk in Hawaii in the 1980s had higher rates of Parkinson's. So the interesting thing when this came out, though, is that people thought this meant that all milk, even today, causes Parkinson's. That's not true, but it's a good example of one way that things might affect your body and your brain indirectly. So our environment contains things like this that may be putting you at risk without really knowing about it. And so it's important for us to look for these factors and to try and advocate for protecting the general public from exposure to these kinds of chemicals. So other things that are important in terms of Parkinson's, we know paraquat is a pesticide that can certainly damage the dopamine cell. Rotenone is a sort of a rodenticide or pesticide that is also known to cause damage to the dopamine cell. And so there, if you go back to the waste disposal analogy, you're creating a lot of waste that the cell has to handle by damaging those cells. And so you may overwhelm your waste disposal system if you're at risk. We still have paraquat being sold in British Columbia. So this is Ministry of Environment data, which I find really unfortunate. But this is something that's not available in Europe. It's banned in Europe, for instance. So this is another way in which we can advocate for protection of the general public. So it's hard to drill down that data and find out where exactly it's being sold and used. But anyway, I've been in contact with the BC government about that. Here's another interesting bit of information. This is, of course, the United States, and this is old data now, but this is sort of a heat map, if you will, of rates of Parkinson's by county in the U.S. So you can see there's some red spots over here. Red is bad here. These tend to be in areas which are involved in industrial processes and manufacturing. So there's some suggestion from some of this data about types of things that may put people at higher risk, including metalwork and things like that. So just before we get into how to treat the motor symptoms, an important thing is that people are very different in terms of how they express these symptoms. So some people have lots of tremor, which is the T. Some people have no tremor. So tremor, rigidity, akinesia, and postural instability is kind of the way people try and remember this in medical school when they're first learning about it. Stiffness is rigidity here, and akinesia is slowness of movement, or we call it bradykinesia. So some people have no tremor with Parkinson's. Some people have lots of tremor. The ways that the movement problems kind of show up are softness of the voice, changes in facial expression and handwriting, things that you use your hands for. So cutting food, getting dressed, hobbies and activities, woodwork, anything you use your hands for, and trouble turning in bed. That's a problem with the muscles in the middle of the body rather than in the outside parts of the body, in the hands and the feet. Trouble standing from low seats like a deep chair or a sofa or a car. That's again middle of the body muscle problems. So we'll keep on moving here. So when we see people with these motor symptoms, stiffness, slowness, tremor, the way we assess whether it's Parkinson's or something else is by going through a careful history and then examining the patient, and then in some cases treatment and then reassessment, in some cases just reassessment and then reexamination. So then over time we generally will be able to pick out what's happening and what is changing, and those are the types of things that we use to make the diagnosis. There's some big studies that have looked at, okay, if we have all the patients that show up with tremor, stiffness, and slowness and walking problems, which we would call Parkinsonism in quotes, how many of them have Parkinson's and how many of them have something else? Most of them have Parkinson's disease. So this is about 80% on average. And then there's some other things, I won't kind of unpack this very much, but there's some things that look like Parkinson's with other features that can sometimes be tricky to diagnose. And then there's some other things that cause Parkinson's that we can see on brain scans, like stroke damage, or that we find in the background. So if there's medications that can cause Parkinson's-like symptoms. So the clinical diagnosis is a very difficult process, and it requires a very patient interview and examination and follow-up. The brain imaging studies we do are usually not helpful for Parkinson's. We expect them to be normal, in fact. This is what they kind of look like. So a CT scan is shown on the left here, an MRI scan in the middle, and this is an example of a research tool called a PET scan that labels dopamine in the brain and shows you what that looks like. So the basal ganglia is this dark stuff, if you can see my hand there, in the middle of the brain. And you can see on a CT it's a little bit sort of brighter here because it's more dense. And then this is called a T1 weighted MRI, and they're a bit darker there because, like the cortex around the edge of the brain, they contain cells. So cells look darker there. A PET scan can attach a radioactive tracer to parts of cell machinery. So it can attach things to dopamine, and then we can see, okay, what's dopamine function looking like in the brain? So this is a PET scan that's got a label attached to something called fluorodopa. So this looks at what dopamine is actually what's happening with dopamine turnover in the brain, so how it's being produced and released. And you can see it looks different side to side. So here where my hand is actually the right side of the brain, and there's less red stuff. So red stuff is more intense uptake. There's more dopamine stuff happening there. So here there's what we call a normal dopamine fluorodopa uptake, and here it's abnormal on the right side of the brain. And this patient here would be expected to have tremor, stiffness, slowness, etc. on the left side of the body, because just to confuse everybody, the right side of the brain controls the left side of the body and vice versa. So we can talk more about that if there's questions, and I see that there's a variety of them building up, so I'll stop for that in a second here. Just another word about MRI. So there may be tools that we develop with MRI that may image iron deposits in the midbrain that we may be able to use for diagnosis, but that's is still something that's only available with very high strength research MRI magnets. So last slide, I think, before I stop for questions, and wow, I've taken a lot of time already. Everybody's different, but over time, things tend to progress. Before diagnosis, some of the things that people commonly report if they look back, changes in sense of smell or mood, changes in sleep, which is something called REM behavior disorder, which is dream enactment, so punching, kicking, tossing, turning in the sleep, and constipation. That can go back 20 years sometimes. And then over time, when you start with these motor symptoms, later you get problems with walking and balance typically, and sometimes cognitive problems. Those usually don't occur for at least many years after diagnosis. But as I said before, some patients will never get some of these symptoms, and no two patients have the same kind of progression. These are just general rules. So I'm going to pause here and look through the questions here. And let's see here. Paraquat, yes, still being sold. Yes, Miriam, many people with Parkinson's do not have tremor at all. Carl, please update us if you've got the picture back. Karen, how soon after a GP thinks it's Parkinson's should you see a neurologist? Well, great question. I can give you kind of like an ideal answer to that. So if Parkinson's disease is suspected, you should see a neurologist. You know, ideally it would be as soon as possible. As you know, in most places in British Columbia and in the world, it takes some time. And one of the things we need to do is make sure that that time is as short as possible. Randy, what is the role of antipsychotics in causing or contributing to Parkinson's? So antipsychotic medications block dopamine in the brain. So if you think about the medication, we'll talk about this more in a minute, but Levodopa basically supplies more dopamine in the brain, and dopamine is released by the brain, and then it acts on some of those other cells in the basal ganglia. So if you think of that like a key trying to open a lock, an antipsychotic medication can be like glue in the keyhole. So if you've got super glue in the keyhole, then no key is going to open it. So basically, they can block the effect of your body's own dopamine in the movement areas. So the result of that can look the same or identical to if you're not making enough dopamine, because it just can't function. If you have a tendency to Parkinson's, or if you have early Parkinson's and the symptoms aren't obvious, you haven't had a diagnosis, and then you get exposed to an antipsychotic medication, that could just make it obvious a lot sooner than it would have been without that exposure. So sometimes we have patients who would probably develop Parkinson's eventually and be diagnosed, who get exposed to one of these medicines, and then they develop their symptoms early. And then we usually have to sort out, you know, how much of that was medication effect, and what happens if we remove the medication effect, and can we still make the symptoms better by supporting the dopamine pathway? Yeah, so So when do we start treatment in Parkinson's? I've said this already, but we treat disability. So we treat problems that people have with their home life, with their work life if they're working, with recreation and social life. So those things are the targets of treatment. The goal of treatment is to minimize the impact of the disease on life and to maintain your quality of life. That's when we treat the motor symptoms. So um, there's a whole variety of different things on the menu. So you can think of it like a bowl of soup, really, because when you take things in through your gut, medications, they go all over the whole body. When they're absorbed, they go over the whole body. And what we're trying to do is usually get them to the place where the movement computer is, which is a specific part deep in the brain. So you can see that there are problems with that system. And some of the medications have been designed with little tricks to help them get where they're needed. So levodopa is the oldest treatment for Parkinson's disease. It's 52 or 53 years now that it's been in clinical use. And there is a phenomenon that's referred to in our field as levodopaphobia. So people are often reluctant to start medication. This mainly comes from concerns that were reasonable and deeply explored about 15, 20 years ago. People were worried that levodopa would accelerate Parkinson's disease. Many people know that there's a phenomenon called dyskinesia where people, when they're taking levodopa or some other medications, can get too much movement. So this has to do with how the brain handles and responds to medication over time. So you could think about this like in the diagram I have here, like, well, this is an oil can, I think, but so oil or fuel, and then parts of the engine. So if your engine is normal, then you won't. The analogy. How was I going to say this analogy? I'm trying to remember. But basically, I think the purpose of this analogy is to say that the effects of levodopa that people are worried about, like dyskinesia, depend on the disease and the medication, not just the medication. So if you don't have Parkinson's, then you could take all kinds of levodopa and you would not get dyskinesia because your brain knows how to handle dopamine properly. If you do have Parkinson's, the ways your brain handles medication like levodopa, it gets less reliable and consistent over time. And that's because your brain is trying to come up with ways to compensate for lack of dopamine. So dopamine cells, they know when there's too much dopamine around not to release anymore. And when there's only, say, 20% of those dopamine cells left, they will release any dopamine they've got on board because your body is so hungry for it. So you get this unregulated release of dopamine that happens as disease progresses. We know if we look at people who've had Parkinson's for 5, 10, 15 years and never been treated, if we put those people on treatment, the rates of dyskinesia are the same as for people who've been treated all the way along. So that was shown by a study in Africa. And what that means is it doesn't matter how long you've been taking levodopa, it matters how long you've had Parkinson's, what the risk is of those complications. We also know that people who start treatment earlier generally do better because they move better and they're more active, and exercise is so good for Parkinson's. So those are kind of the points I wanted to make about that. And I know there will be questions, and I'll try and come back to that. Amantadine, so where are those capsules of amantadine? We can't get these capsules anymore of amantadine. It's a medicine that was actually an antiviral medicine. It has effects on dopamine in that little synapse in the basal ganglia, and it has effects on other brain chemicals, so glutamate. And so what the symptoms that it helps are, it sometimes helps with fatigue, tremor, and possibly walking. And it has been shown to reduce dyskinesia in many patients. So there is an extended release form that's being tried in a study, and that may relate to why there's no manufacture of the old standard amantadine. People can still get the syrup in most cases of amantadine, but it's been a bit hard to come by for the last 6 to 8 months. Motor symptoms, so the tremor, stiffness, slowness, etc. um, are treated with a lot of these different things. So levodopa, dopamine agonists, amantadine, and some other things. So rasagiline or Azilect and selegiline are called MAO inhibitors. And I don't want to spend too much time on brain pharmacology because it's confusing and boring, but we have lots of different medications to treat the symptoms. And basically what we do is we try and adjust medications to get people moving well or not having motor disability for as much of the day as possible. That's basically the goal of our treatment plan with medications. And when we have problems with the symptoms kind of fluctuating, we adjust the doses, we change the type of the medication we're giving, we add other things. And some patients need advanced therapies. And the common things that we talk about are deep brain stimulation and duodopa. So those two advanced therapies are generally expected to have more reliable and consistent effects on motor symptoms than the medication. But they have other issues, and they're not something we usually do right at the start of a treatment plan. Boy, this is a lot of information, isn't it? Okay, I'm going to stop again real soon. Tremor, we've talked about how not everybody has tremor, and not all tremor in Parkinson's disease gets better with dopamine medications. It's important to know because often people are concerned if their tremor is not gone, that they might have the wrong diagnosis. So it does, of course, require a careful assessment, and it can be tricky with tremor if tremor is not accompanied by slowness and stiffness to make the right diagnosis. But generally, if your neurologist is confident and tremor is your main symptom, it doesn't mean that they're wrong if the tremor doesn't go away with medication. Stiffness and slowness should almost always improve with dopamine medication. And this goes back to one of the questions about how we distinguish something like drug-induced Parkinson's from Parkinson's disease. So if symptoms like stiffness and slowness do not get better with levodopa, and we're quite sure of that from a careful examination, then we raise an eyebrow and a red flag because we might have to rethink what's really happening. There's some other emerging treatments for tremor. High-intensity ultrasound, it works for essential tremor. It probably will work for Parkinson's disease, and it's sort of a similar kind of concept to deep brain stimulation, which I'll talk about briefly in a minute. Falls, yeah, people have falls. Sometimes not everybody, again, has falls. And there are some treatments we have that help with preventing this, and a lot of the activity things like exercise, tango, Tai Chi, cycling, yoga, they may help with fall prevention. I know someone's going to ask about cannabis, so I'm just going to say a few things up front. So at the moment, like the state of the art is that there's no good quality evidence to show that cannabis helps Parkinson's disease. Anecdotally, a lot of patients find that these things are helpful for certain symptoms, and this can be true of cannabis, and it can be true of other things. So some people use it to help with sleep or anxiety or nausea or appetite problems or if they have pain. But there are potentially side effects. And there are a lot of vendors that are selling these products to patients with sometimes claims that are not supported by good studies. So I encourage people to be very precise about what they're trying to do. And how they will decide if it is actually doing what they hope it will do, and to be very mindful that it could have potential side effects. You should think about anything you take for Parkinson's disease like you'd think about a medication. So what goal do you have in taking it? What side effects could it cause you? And what's the cost of it to you? So the other real challenge with these products is if they're not regulated and vetted by Health Canada, they don't have a drug identification number. We don't really know what's in them. It could be mystery meat, and people will often say they're going to provide a high CBD product or something like this, but it's really difficult to know exactly what's in there unless you really trust the source of your product. So at the moment, I don't have evidence to recommend cannabis products for patients with Parkinson's, recognizing that a lot of people will take these products and other things anyway, I just encourage people to be very cautious with this. Okay, so this is another place that makes sense for a break. I see there are 6 minutes left in the presentation. We've covered a lot of information already, and I want to touch on some of these non-motor symptoms. So perhaps what I'll do is I'll just briefly go through these non-motor symptoms and then take questions. So we've talked mainly about movement problems with Parkinson's. Some of those other brain chemical systems that are involved can lead to other what we call non-motor symptoms. So sleep disturbances extremely common. They range from restlessness, sleeplessness, problems moving overnight, frequency of urination. Somnolence just means daytime sleepiness. Fatigue is extremely common. And then I've mentioned this already, but dream enactment behaviors, so punching, kicking, tossing, turning in the sleep. This is an interesting study just to show you that melatonin, which is a natural kind of brain hormone that you produce, it has a lot of effect on your sleep-wake signal in your brain. And when measured in people with Parkinson's, that's the black little dots, and people without Parkinson's, that's the red dots, you can see people without Parkinson's produce a whole lot of melatonin at night, and people with Parkinson's produce a little bit. So for that reason, we often suggest if people have sleep problems, they try and take supplemental melatonin to see if it helps. Melatonin, it can in some patients cause vivid dreams, and if you take melatonin, it can sometimes cause grogginess in the morning if you've taken a large dose, for instance. Many people find a small dose is helpful. Some people find they need a large dose. But this is something to talk about with your doctor if you have sleep problems and you're curious about it. Depression is extremely common, and this little guy here is shouting. Anxiety is also common. These are extremely common, almost universal features of Parkinson's disease. And so if they are influencing your function or impacting your ability to move, to be active, to get out of the house and do things, they're important to address in some way. And that might look like support and counseling. It might look like medications. I often get questions about razajin, which is called Azilect, and antidepressant medications in combination. There's a flag on pharmacy databases about the two being used together because drugs that are related but somewhat different than Azilect can have a serious interaction with a lot of antidepressants. In practice and in reality, the risk of having this problem called serotonin syndrome with Azilect and a standard antidepressant is very low, and we often will just cautiously ensure that it doesn't happen, but it's very, very low. Memory problems. We usually do a multi-pronged approach when people complain of memory problems. First, we see, are there things that they are taking that could make the problem worse? We look and see, are they undertreated or overtreated with dopamine, because both can contribute to memory problems. And then sometimes people need treatments that can help the memory problems. So there are some more complicated brain symptoms that can come on in patients. So hallucinations or delusions occasionally can happen. Again, not everyone will get this, and it might never apply to people with Parkinson's. But when it does, it has to be treated very cautiously. The question came up earlier about antipsychotics, which is usually the first thing that happens if people hallucinate. They're treated with antipsychotics. There are some of those medications that can harm people with Parkinson's, so it's important that if there is this kind of problem that's being treated, it's run by a neurologist. There's a lot of plumbing problems, so constipation and bladder problems are again very common. For constipation, I usually say start with the 4 F's, which is fiber, fruit, fluid, and fitness. And there's actually clinical trials of Metamucil or Psyllium for constipation and Parkinson's that show that it's helpful. And there's studies that show that something called PEG, or polyethylene glycol, is helpful. And there's some other things that are very commonly used. And that's something that usually is also discussed with either the family physician or a movement disorder specialist or a nurse specialist. But it's important because if you have bad constipation, it can actually affect how other medications work and things like that. And the bladder thing, most people have overactive bladder symptoms to some degree at some point in the illness, but not everybody. And sometimes those respond to medications. You have to be careful about which ones, though, because some of them can cause memory problems. It's complicated, isn't it? Dizziness. This is a common symptom as well. We need to be careful with blood pressure in Parkinson's. Sometimes medications we use can make the problem worse, and sometimes not. I guess I'm being vague because it's so different for everybody, but if people have lightheadedness, meaning they feel like they're going to faint when they stand, the first thing to do is measure the blood pressure, laying down and standing up, and make sure it's not going too low. There are a lot of lifestyle and dietary changes that can resolve the problem if it's there. So the important things with diet are large loads of carbohydrate, like a huge bowl of pasta or eating a whole funnel cake, will drop your blood pressure really quickly. So I often ask people to review their diet if they have this problem, and if they do get lightheaded, then look at taking smaller, more frequent meals rather than big loads of pasta twice a day or something. And then getting adequate fluid is also important for people with dizziness and from low blood pressure. I could talk about that for 20 minutes too. And neuroprotection, neurorestoration. Oh my goodness, I could talk about this for another hour. Let me give you a little summary. I'll get to the end of the slides, and then I'm going to ask for questions and go through the chat questions. So this is the holy grail. We need something that's going to slow down the progression, the rusting of the barrel, and we still don't have a medicine that is proven to do that. There was suggestion that some medications may do that, and the most promising one that is available for Parkinson's is Azilect, which is called razajin. And razajin does help the motor symptoms of Parkinson's for most patients, but there was a suggestion that it might slow down progression, and the clinical trial data was controversial. Still to this day, we don't have a medication that's proven to slow down Parkinson's, and that's what we're desperately needing in the field, is something that's neuroprotective or restores brain function to something that's better overall. The other big need we have is ways to track the effectiveness of these kinds of treatments. So we call them biomarkers, and ways to identify people before they have tremor, stiffness, slowness, etc. Because maybe if we can get to slowing down the disease before people develop symptoms, then we may prevent disability in the long run. So if we have these kinds of things, they should be started early. And the last big unmet need is how to get most people or all people with this diagnosis exercising safely, because exercise does slow down the progression to some extent. And what kind of exercise? Well, probably lots of different kinds. And I usually tell people it's whatever you enjoy doing. If it gets your heart rate up, if it gets you breaking a sweat, that's probably good. If you're building muscle strength, it's better to have strong muscles in Parkinson's than weak muscles with Parkinson's. So I usually tell people to try and find what they enjoy and support them to do that. If there's barriers to it, then those barriers need to be kind of addressed and looked at and removed. This is the last practice parameter for Parkinson's disease in Canada. There's another one being produced that should come out in the next year. So the statements of this are kind of very basic. So the statements at that time were levodopa does not accelerate Parkinson's disease. That's still true. No treatment has been shown to be neuroprotective. That's still true. There's no evidence for vitamin or food additives to improve function. Unfortunately, that's still true, although a lot of people will still take things. And again, I say if you do so cautiously and you have clear goals and expectations, that's fine. And exercise may be helpful. Well, we think exercise is likely helpful, but that's sort of the bottom line with what we know about things. I could drill down into this a lot more detail, but there have been a variety of trials looking at different supplements, vitamins, etc. And there's no good data that any of them stop or slow down Parkinson's disease. Although there's some suggestive information about a variety of them, I'm going to just skip over that. And there are a variety of things that are being studied to slow down Parkinson's disease, including some other supplements and nutritional things. And I think the future is still bright. There are some really promising therapies in development.
Thank you very much, and thanks for answering their questions. It means a lot to the population, and it gives them, a little bit more direction as to where to go and what to look for, and kind of how to move forward with this on this journey. So I really do appreciate you taking the time and going over time with us, because, like you said, you could talk about probably one thing for a long time. So we should plan for like a week-long course. No, I'm kidding. But it's been very helpful, so I really do appreciate everything that you've covered so far.
It's a pleasure. Yeah, thank you for attending, and thanks for inviting me to do it.